Good afternoon, everybody, and welcome to this afternoon's session on using telehealth to strengthen the healthcare workforce. I'm Jonathan Neufeld. I'm the director of the Great Plains Telehealth Resource and Assistance Center. And I wanted to just give you I wanted to share a quick little point or two about the telehealth resource centers. We have been partners of HRSA for a decade. We are, or more at this point, we are scattered around the country with regional centers covering 12 different regions within the country and 2 national centers focused on telehealth technology and telehealth policy. We are all, you can reach us all at the telehealthresourcecenters.org domain. There's a national website there with links to all of our regional health centers across the country, as well as the nationals. So this is a free resource that's been supported by HRSA for years and OAT for years, and it is really a fantastic resource. And I just want to encourage you all to take advantage of those programs. This afternoon's session, as you know, is about telehealth and what telehealth can do to help strengthen the healthcare workforce. There are lots of things, lots of ways that telehealth does this. Of course, we know by now it doesn't just create providers, because we're going to have a provider shortage for the foreseeable future here. But there are a lot of creative things that telehealth allows us to do to help promote workforce availability and help us make the most out of the workforce that we have, including adopting various versions of a location-agnostic workforce, addressing the barriers that come up with that sort of a scenario. And then there are going to be some new and emerging opportunities that we are going to hear from now, hear from this afternoon, as well as others that you may not hear from today, but certainly are out there. And we want to point to those and also address those in the Q&A period at the end of this session. If you have questions, put them in the Q&A feature, and we hope to have time to address those at the end. And now I'm going to turn it over to the first of our speakers. I'm going to let you all know that there are 3 speakers, and they will just proceed one right after the other. Sandy Chung from the Virginia Mental Health Access Program, Robert Stiles from the University of Kansas Medical Center and also the Heartland Telehealth Resource Center, and Lisa Robin from the Federation of State Medical Boards. So I will stop there and turn it over to Sandy. Take us away.
Great, thank you so much. Let me go ahead and get my slides up. So my name is Sandy Chung, and I am a president of the American Academy of Pediatrics nationally. Also happen to be medical director and founder of a program called the Virginia Mental Health Access Program, which is what I'll be describing today. So specifically, I'll be talking about using telehealth to strengthen the pediatric mental health care workforce. I don't have anything to disclose. And really first, just to talk about the problem briefly, in case you don't spend time in the pediatric mental health care space. The pandemic, we all know, has had an impact really for the entire population, but has very much had an impact on children. And COVID-19 and the efforts that we put in place to mitigate the spread of the disease has had a significant impact on families over the times of the pandemic, but also now that the disease has changed, we're still dealing with the ramifications of the social isolation that was in place, the economic impact that families had, and we all know about different areas of this where we've had risk factors that have worsened the mental health of our patients and our population. Parents themselves and caregivers themselves also were directly impacted. We also know about COVID-19 and the deadly impact it had on many people, especially in the adult population and our elderly population. And numbers are higher than this now, but as of May 1st in 2022, over 250,000 of children in the United States lost a primary and or secondary caregiver, with our Black youth experiencing a disproportionate loss. So the impact of orphanhood, as we all know, is a lifelong condition. And so as we think about how do we work with mental health and the workforce, and how do we as pediatricians manage this, there's a lot to do and a lot to think about. Additionally, suicide is the second leading cause of death for young people ages 10 to 20 24 years of age during the pandemic, even though we saw lots of people in the emergency rooms on the adult side. We actually, for children, saw fewer kids with illnesses. When they were at home, not in school, we had fewer viral illnesses during the 2020-2021 timeframe. But what we did see is an increase in mental health visits to the emergency rooms. And it wasn't just our adolescent population. We saw it for all ages of children down to some of our youngest. The trends are not going in the right direction. So even before the pandemic, youth mental health was in a crisis scenario. So this is from the CDC, and you can see that since 2011 up to 2021, that we're seeing more young people who are thinking about suicide, who have contemplated it, even made a plan or even attempted it. And again, this is not something new. It's just been worsened by the pandemic. So here you can see from 2009 up to 2019, which is before the pandemic, we were already seeing an increase in young people who were suffering from mental health conditions. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatrists and the Children's Hospital Association in 2021 declared a mental health emergency, a national emergency in youth mental health. And then we renewed that declaration last fall. And that was important for advocacy purposes, for awareness purposes. And I think very few people now don't know somebody who has been suffering from a mental health condition. And unfortunately, with children, we know that there's a lifetime consequence if we don't intervene and help them early. So changing how we approach children's mental health is key, and having a transformative way to do that. And telehealth is very much a part of that work, as many of you know. And so pediatricians are in an interesting place where we see children from birth all the way through young adulthood, and we have a longitudinal relationship with families. And so we are in a very unique place where we identify often first that there is a behavioral or mental health concern. We know that children and our, healthy emotional mental health development happens over a continuum. So, even to prenatal, how mom is feeling, how the family unit is feeling, and the environment that a child is growing up in really has such an impact on how a child's mental health develops. So there's systemic factors like disparities in access to healthcare. There's access to community resources. There's interpersonal factors. What's your family relationship? What's your caregiver relationship and your peer relationships? There's exposure to trauma and systemic racism, and so many things that impact how a child's mental health develops. And schools are another place. The pediatrician's office is one place, and schools are another place where we're seeing this come up over and over again. And so having schools work on this is important. Having pediatricians who work on this is important. And really anyone who touches the life of a child. This is a joint effort. We have to do this all together. There's a particular shortage in child and adolescent psychiatrists. So when I first started practice, I was taught to identify that a child may have a mental health condition and then to refer to a child psychiatrist. But there just aren't enough of them. And because there aren't enough of them, as a result, pediatricians end up being that default provider. At the American Academy of Pediatrics, we do a survey, longitudinal survey of our pediatricians. And this survey is, most of them are now in their mid-careers. And we ask them, is it hard for you to find mental health care for your patients? And they are, as you can see here, they work in different settings. So they might be in primary care or inpatient subspecialty care or outpatient subspecialty care. And normally green means good, but here green means it's very difficult for me to find care for my patients who have mental health conditions. Blue is moderately difficult. Yellow is somewhat difficult. And only that small sliver of reddish orange are those providers who are able to find care for their kids. So primary care pediatrics is really what we turn to say, okay, we're seeing the kids in our office. We know that they have a need. How do we address that need? In particular, when we weren't trained to necessarily manage that. That's changing, but certainly there's a whole cohort of pediatricians and nurse practitioners and PAs out there who were not taught how to manage primarily mental health conditions like depression and anxiety, ADHD, bipolar disorders, eating disorders. And so advocacy has been very much a part of that. And AAP, we set strategic health priorities every year, and you can see healthy mental and emotional development is a priority for our academy. And advocacy to Congress, and this is just a photo of me having an opportunity to testify before Congress, saying this is important, we all know it's important, but here are some concrete things that we can do. And what's been exciting is that Congress has heard us. And so with the HRSA program, that we have what's called the Pediatric Mental Health Care Access Program. And this is what I founded in the state of Virginia. But this program is funded through HRSA in order to expand access to telehealth care, not necessarily directly to the patients, because that is a model, but when there aren't enough providers, having just telehealth access to care is good, but it's not going to answer the workforce shortage question. So what these programs do instead, and I will go into Virginia's a little more deeply, is that we actually teach the primary care providers. So those of you who are familiar with Project ECHO, it's a little bit like that, so we train first and we teach primary care providers how to do this work, but then they need help as a physician, as a provider, I need assistance because I'm not a child psychiatrist. So how can I use telehealth to reach my specialist, my child and adolescent psychiatrist colleague to get advice? And then how do we also help the families find care? So I'll go into more detail about our program shortly. But as you can see here, now across the country, we have funding for programs just like this in nearly every state and territory. The dark blue ones have funding from HRSA. The other states that aren't in dark blue also have programs. They may just be funded differently. So let me tell you a little bit about what the program actually is that may help to describe it. And so let me first tell you what happened. So in 2017, I'm a pediatrician in a very large practice. We have 180 clinicians and 30 locations in DC, Virginia, and Maryland. I run this group, and then I'm also a primary care pediatrician. So in 2017, I had a 14-year-old young man who was a patient of our practice, and he had a complex psychiatric condition. He had bipolar disorder. He was on 5 different medications, and his child psychiatrist retired. And so the family called us to ask for help. They said, our child psychiatrist retired. We called and we got an appointment, but it's not for 4 to 6 months from now. Can you refill his medications? And when we looked at his medications as pediatricians, we weren't comfortable with them. We weren't trained to use these medications. We didn't know how to prescribe them or manage them. And also in our state, Medicaid would not pay for them if a psychiatrist didn't prescribe them. So we said, no, we can't prescribe them for you, but what we can do is help you find an appointment. So we called and we called and we called, and we finally got him an appointment about 4 weeks later. So we thought we were in good shape. But unfortunately, during that time, he ran out of his medications. And when he ran out of his medications, unfortunately, his disease got out of control. And then he got into a fight. He got into a fight in a parking lot, actually near my office. And during that fight, unfortunately, he had a gun, and he actually shot and killed somebody. So that 14-year-old ended up in juvenile justice, and that other man lost his life. And because of that, I went on a quest, and I said, gosh, there's got to be a better way to do this. If we knew how to manage those medicines, if we were able to call and speak to a specialist to get advice on what to do. And also we have health systems issues, right? We have if Medicaid paid for the medications, so there are all these different things that needed to change in order to change that outcome. So in Virginia, we have the same problem that's really across the country. So many of our high schoolers report that they feel sad or hopeless. Many of our middle schoolers and high schoolers have even gone so far as developing a plan or thought about killing themselves. In Virginia, we actually rank 48th lowest in the country when looking at the access to mental health care for our young people, so access to psychiatrists and counselors and psychologists. And so only 4 of our counties have enough. So here's a map of Virginia, and you can see the green counties have enough child psychiatrists for the number of children in that county. And then the yellow, there's a shortage, and then orange, there's a severe shortage, but the red counties don't have a child psychiatrist at all. And when we asked our pediatricians, are you seeing mental health issues? Is COVID changing that? And the answer was absolutely yes. 90% of our pediatricians said that they were seeing an increase in mental health issues and behavioral health issues in their patients. And then more than half, 62%, said they could not manage it. The little bars, I know it's hard to read, but the most common conditions we're seeing are anxiety and depression. And then we asked our pediatricians, do we need something like a mental health access program? And there was a resounding yes. The first bars are asking, is there enough access to child psychiatry? If you just refer your patient, well, can they get an appointment? And the answer was no, they cannot. Or if you're trying to refer for therapy, can they get an appointment? The answer was no. And then the third one is, I can do this as a pediatrician. I know what to do. And the answer was no. And then the fourth one was, could you even call a child psychiatrist if you had a question? And the answer was no. And so the Virginia Mental Health Access Program, which is, like I said, now there are programs like this in nearly every state, have multiple parts to it. Not every program's the same, but in Virginia, what we do is we educate. So we teach the primary care providers, pediatricians, family physicians, nurse practitioners, PAs on how to do this work. So we use Project ECHO. We use something called the REACH program, which is like a weekend program followed by Project ECHO-like sessions for the next 10 months. We do quality improvement projects. We have QI programs where they can get credit for their certification as physicians and as nurse practitioners. And then we have a guidebook that we put out. And then for the telehealth portion of this, we have a consult line. And so here we have child psychiatrists who are available so that within 30 minutes, any primary care provider in the state of Virginia can call and talk to a child psychiatrist and get advice on what to do with the patient who's right in front of them. We also have licensed mental health providers on the line, and we have care navigators. So if I have a patient, for example, if I have a 12-year-old who has Medicaid or who has commercial insurance, and maybe I think they have an eating disorder, then I can call VMAP, and then a care navigator actually reaches out to the family and helps them get an appointment in the community. Here's another way of looking at it. So first we educate the primary care providers. Then if they have a question, they call VMAP. And then the call is then routed to whichever service is necessary. We're divided into regions across our state. So we have our academic institutions helping us. It's been a wonderful multi-collaborative effort. We have now trained over 1,000 primary care providers. We've done actually almost 5,000 calls at this point, and then we've done 22,000 hours of training using telehealth. Our call volume is here, and you can see year over year that's increased as we've expanded. And then we've been able to fund the program, both not just through the HRSA funds, but we've gotten funding from our state to continue to expand this program. Educational, we use Project ECHO, as I mentioned. We also use Project ECHO plus quality improvement projects. And then we also use this program called the REACH program. The guidebook I also mentioned, and this has been great, and it is free online. All of our resources are free online. So if you have interest, feel free to go to vmap.org and look for resources. We're happy to share with anyone who's interested. And our guidebook covers things like this, and it's really meant to be a quick reference for our workforce so that as primary care providers, we can learn more on how to do this work. We are expanding our program to incorporate early childhood so that similarly, there are not enough developmental behavioral pediatricians. So for example, if I see a 2-year-old or 3-year-old who I think may have autism, the current wait time to see a developmental behavioral pediatrician is 1 year. And so when you have a 2 or 3-year-old, you absolutely cannot wait a year in order to get a diagnosis and to get care. So we are now using VMAP, the same model, to train our primary care pediatricians and family physicians and nurse practitioners on how to diagnose autism and also work on other early childhood behavioral issues. And then we're also expanding to moms. And so some of the states have already done this, but this is similarly, OBGYNs and pediatricians often are the ones diagnosing peripartum mood disorders like postnatal depression and anxiety. And in order for us to do a better job of managing that, teaching us how to do that work, and then providing a telehealth consult so that we can talk to a psychiatrist or psychologist who specializes in this work is key. And then also having care navigation resources. This has been a multi-agency and multi-organizational effort, very collaborative work across our state. We're really proud of it. And it is working. We have had multiple providers tell us how impactful it is. And we've had, even more importantly, had patients tell us how impactful it is. I had a mom come up and tell me that she had a 24-year-old child and a 17-year-old child. When her child, 24-year-old, had anxiety and depression as a teenager, her pediatrician didn't know what to do and just referred, and it took almost a year before that child got care. And then now that VMAP's in place, she went to that same pediatrician with her now 17-year-old, her second child, who had similar conditions, and her pediatrician knew exactly what to do and was able to take care of her child immediately. So that's the end of my presentation. Thank you so much for your attention. And now I'll turn it over to Robert.
Great, thank you so much. I appreciate the opportunity to be here today. Let me get my screen up. There we go. Sorry, just one second. For some reason, there. Hopefully you can see my face. So I'm Robert Stiles. I work with a program called Telehealth Rocks at the University of Kansas Medical Center. But I kind of have a pretty broad history when it comes to the workforce. I used to be the director of primary care for the Kansas Department of Health and Environment. So, kind of came at it from the workforce side, shortages, National Health Service Corps, things like that. Then I went off to run FQHCs, and here I am back in academia now at the University of Kansas Medical Center. So we're going to start by talking a little bit about our program, and then I'll kind of get into why it impacts or has a role when it comes to the workforce. So Telehealth Rocks is a program, stands for Regional Outreach for Communities, Kids, and Schools. Yeah, you're going to get 2 pediatric presentations in the workforce training today. So when we talk about what brought us together, what keeps us together, we have this vision of schools and communities where every child has the resources and skills they need to have the exact same opportunity for success in school and in life. So you might think, what does that have to do with the workforce? So when we think about telehealth and the healthcare workforce and using telehealth and training the workforce tomorrow, telehealth is a method to achieve a goal, right? Access to healthcare for populations who lack them. Sandy just did a great job talking about the role that telehealth can play in telementoring and kind of providing services, providing access to services through training in other ways to help the workforce that exists to meet the needs and also to create new workforce models. So when I think about the workforce, I realize that we have to support, amplify, expand, and train the workforce if we ever hope to achieve a community where every child lives in an environment and has the resources they need to succeed. So we need the workforce, right? And we need all components of the workforce that are interacting with children to make our society work better and to be more successful with our kids. So I kind of say that we have to collectively and collaboratively change everything, and that's going to take us all. So our program first got funding from the Office for Advancement of Telehealth going back to 2015. Since then, we've sort of grown and have currently 2 Office for Advancement of Telehealth grants, as well as a SAMHSA, Advancing Wellness, Resilience, and Education grant. So when I think about sort of who we are, one of the things that is really important to me to think about is you have to kind of talk about our different programs. We have different funding for different programs, but I see silos as the problem. When we talk about the workforce, when we think about supporting the workforce, when we think about using telehealth, we kind of have to think about the broad perspective and sort of the breadth of components. And so you can't, put our training grant in one area and not talk about everything else that we do. So we've now come to a model where we see clinical services, training, student prevention services, engagement, and family support being sort of part of a continuum. This is our current model. We used to have a pyramid, but I really like this idea of everything flowing into each other. And the concepts that we focus on are that we're school district driven and centered. We see schools as central in rural communities. We focus on rural communities. I guess I should have mentioned that. We think it universal targeted and individualized services. So we do provide clinical services, we do provide telehealth services, but we also focus on the social determinants of health as a behavioral health intervention, as a universal intervention on behavioral health, and being trauma responsive. Sandy did an excellent job talking about the traumas and the after effects that we've seen from COVID and the pandemic. So many other traumas that children are exposed to on a daily basis, just sort of traumas of poverty, actions that happen in their lives. So the other thing is we do want to really provide training and resources for schools, clinicians, communities. We believe that everybody kind of needs to be in there. We're really going to impact what kids need, that we want to create an integrated system, that we believe in collaboration overall. So we're going to have a massive network, which we'll talk about in a little bit. But we want to focus on the school and the community priorities, what's happening at the local level, what the needs are at the local level. And then we do focus on students and populations with specialized needs. Some of the areas we've moved into is looking at new immigrants in rural communities, youth involved or at risk with the justice system, foster care, protective services, youth with intellectual developmental disabilities. So what have we learned from this work over the last few years, or I guess 8 years now, that we have to simplify. And I think we'll see in a second why I think these matter to thinking about the workforce and supporting the workforce and training the workforce and everything that we can use telehealth to help with. So we got to be a big tent doing a few important things together. The biggest thing that I see, I'm a big fan of saying there's enough money in the system. It's just, we've got enough money to resolve our issues. We've got enough money to meet the needs. It's not coordinated. We do have to have capacity. We have to meet local needs with the level of existing resources. We can't add a lot of resources to the system. We have the most expensive healthcare system in the world. I think we can afford to figure out how to do things better. We have to coordinate, we have to understand the landscape, who's working in it, what they're doing, and those things that are working and already exist, we should help make bigger, right? So there was a great juvenile justice focused program that one of our partners did. And so now we're expanding that, using funds to expand an already existing, successful program, rather than creating our own. We have to focus. We have to understand the needs of each school and community and the children and the families. We've got to know who we're serving. So it takes all of us, and it needs the entire workforce, and we need to think more broadly about the workforce if we're really going to meet the needs of our kids. So how are we creating the workforce of tomorrow? Well, I think we have to expand our concept of the workforce from healthcare to everyone impacting the health of a child. So for us, we focus on pediatrics, but you can do a similar idea for adults. What impacts their health? So for us, we look at school nurses, school counselors, school psychologists, special education, parent teachers. We've got to add new tools. One of the things we're doing is school-based community health workers, which I've been really excited to see Kansas now adopt statewide. We got to go upstream to prevention because we're never going to have enough workforce when we keep adding to need. So I sort of anecdotally say a lot, let's quit harming kids, right? Let's deal with the needs we have. Let's get the services that are needed. Let's find and create the workforce that we need. But I've been at this for 25 years now, working with workforce issues. We are never going to have enough psychologists. We're never going to have enough pediatricians. We're never going to have enough psychiatrists, and we're certainly not going to have them where we need them. We got to reduce the need. And we have to make it easier and more rewarding to do our jobs. One thing we learned during the pandemic was self-care is a bad word, right? We're telling nurses and healthcare staff and schools, take time or have somebody take your classroom, and take a walk around. There's no time for self-care. And we started turning this into a bad word. So one of the things that we came with out of that was this idea that we're going to either replace current practices with a more successful one, right? We're not going to add to your workload. Or we're going to add, if we're adding to the workload, then we need to add resources to the environment. So, I've really come to this idea, whether it comes to how are we improving population health. This is the model, right? We talk a lot about 20% of your health comes from the healthcare you receive. But I really find that one of the things we're doing, both to educators and to the health workforce, is we're asking that 20%, right? That they interact with you in that 20% level to fix 100%. And then we wonder why they don't go to our trainings, why they don't use our best practices, why we can't find enough staff. So using telehealth to strengthen the workforce, what is important and what have we seen as successful? First of all, I feel like it has to be comprehensive. So we had a medical complexity outcome that focused on the coordination between school and the clinician. That was the first time. We offered it the next year. We talked to schools and worked with them on how do you impact the social determinants of health? How do you take into account the social determinants of health as it comes to the medically complex child? And then our third go around, and we'll probably keep doing this until we run out of people to talk to or ways to support that child and their family and their needs. So the third time was how can schools support families? We're just going to keep at it with everything we do until we hit everything, until we bring people together, until we create the linkages that need to exist so there are less and less silos, right? Things happening side by side by side. It needs to be responsive. So we ask those who participate in our trainings and our partners at least twice a year, what do you need and what are you struggling with? So keeping kids safe, suicide. We heard from Sandy, suicide has been such an issue. It continues to be an issue. It's always been an issue, but it's gotten, even worse. But then they told us we really need to hear about social media and substance use and bullying and self-harm and disordered eating. So this year we took that training series and we're doing short series on each of those issues with experts in the field. Similarly, one ECHO series we offer called Better Behavior Together, which we've been offering at least since 2019. That's always had KMC behavioral health experts, right? Which is great. One of the things we sell that with is that you get free advice from, you get to work and hear from and talk to and learn together with experts in the field. But this fall, we're going to have it led by a long-term school therapist and school district special education director, because what we found in those echoes is the people that had the best ideas were the people working in the field that had dealt with these issues with kids in their own schools. So what's next? Whatever our partners and participants tell us. We do not offer something unless the people that have participated in our echoes tell us what they need. Expansive. One of the things we added to our model was school-based community health workers, along with new models focused on the risk of foster care, juvenile justice involvement, and new programs. Attendance-focused community health workers. What we're hearing now from schools is attendance. Post-COVID, there's a massive study that just came out. It was reported in the New York Times, but also you go read the article, right? Attendance has really gone downward in school, and kids can't learn, and they're not successful, and they don't have access to what they need when they're not in school. We're adding 2 new pediatric clinical postdoctoral fellows that are going to be supervised by KU Med, but they're going to be virtually supervised, and we're going to place them in the rural communities we serve. Just want to point out that in 30+ states, community health workers are billable Medicaid providers in at least some situations. Here in Kansas, we just got a state plan amendment approved. So CHWs are billable providers for Medicaid across the board. We have to be receptive. Our participants and our partners told us they couldn't always attend our trainings, and that hour-long videos were not always possible. They couldn't come at the time we had them. So we put together a new website. They told us I need 5 minutes that I can show at a staff meeting. So we started creating that. We started creating resources and posters and even books for use in the classroom. Last fall, we kind of revamped our Resilient Self-Care Echo, and everything we did, we gave them the tool they needed. We identified what they could replace, gave them the posters. We said, we're not going to ask you to do anything without replacing something in your current work or giving you what you need to do the work, so you don't have to. We're not going to ask you to go print off our posters, put them in the mail to you. Then we have to talk about how does any approach we're pushing for replace current practices within the time available. We're not going to ask for more because there isn't more. Nobody has more time. Nobody has more capacity. We got to work smarter. We got to help them get things done better, help get the resources that they need. And then what do we have to add to the system? The system needs things added. School-based community health workers, right? Schools, I started putting therapists in schools back in 2011 because schools were dealing with things that needed a therapist, right? I put a first community health worker in a school in 2017 because schools have to deal with, the kid can't learn if they're not eating and they don't have the clothes they need. And, so we put that on the school. We tell them they're successful with the success of the child, but we don't give them the resources that we need. So we believe that we have to add to the workforce. We have to add to the system those things that are needed. And it has to be inclusive. Got to have everybody at the table, and we've all got to be working together. So here's our partners. We work with HRSA, SAMHSA, the NIH. We have the State Public Health Agency, the State Mental Health Agency, the Family Protection Agency, the Department of Education. We also work with a couple of those in Missouri as well. Bring in our State Prevention of Substance Use Coalition, Suicide, IDD Family Advocacy Organization. Healthcare, we have the 16th largest rural FQHC in the country, a mental health center, our own academic medical center, 11 school districts, statewide education service center, and we'll bring in everybody else, and we're going to keep adding until we change the whole system. So recently, now have strong relationships with juvenile justice, with a foster care contractor, with regional family services agents, faith-based organizations. We're just going to keep going until we change everything. So why do we need to change everything? Because the health and the education workforce, right? We see the education as they're our healthcare workforce too. They're making healthy kids. They're helping kids be healthy. And they're tired, they're burnt out, they're exhausted, they're overwhelmed, they're unappreciated, isolated, unsupported, and they are quitting. We've got to do something. So I think it's simple. We focus on the environment, we focus on the individual, we focus on the community, and we have to do all of that to have an effective and motivated workforce. So Why do we focus on the needs of the workforce along with everything else? Why do we think the workforce is important? Because children and their families need our help, and it's going to take us all. So I appreciate being here today, and I'm going to pass on to Lisa now.
Okay, thank you. Such wonderful programs from our colleagues. I am going to talk a little bit today through the lens of the licensing boards. First, next slide, please. I work for the Federation of State Medical Boards and have for a long time. We represent, for those of you that are not familiar with us, we represent the 70 state medical and osteopathic boards in the country. These boards really are responsible for the regulatory oversight of all physicians and the vast majority of physician assistants. Many other boards have responsibilities for various other health professionals. But from our point of view, the FSMB has looked at workforce, and we can all agree, we know the projections are grim. And as our population have more and more needs in all areas of care, trying to look at reducing administrative burdens and looking at ways, mechanisms to allow our healthcare workforce to practice in multiple jurisdictions and to be able to, particularly to provide telehealth services across state lines. Next slide, please. So the FSMB has been looking at this issue actually for decades. Our first telemedicine policy came out in the late 90s. And since then, of course, things have certainly evolved. We've been involved with through the License Portability Grant Program for many years, and it's really allowed us it served as a stimulus to really get the boards to look at how to not only to retain some regulatory oversight, but to really try to really achieve some sort of license portability that would enable professionals to practice in multiple jurisdictions. We are currently in our 5th year of a grant, and those funds are really being used to support the Interstate Medical Licensure Compact, as well as develop and promote a licensure compact for PAs. Another major project for us really arose in response to COVID, to the pandemic, and looking at how do you mobilize the workforce and allow health professionals to practice in multiple jurisdictions with a easy, rapid way to verify their credentials. We also have some telemedicine policies in place as an organization and trying to look at exceptions to licensure, as many states are doing, for the purposes of telemedicine. Next slide, please. So it has become, looking at workforce and improving our ability for professionals to practice across state lines, it has become apparent that a compact, an interstate compact, has become the preferred mechanism, if you will, to support license portability. There's many benefits to that. It can certainly facilitate multiple practice. It can improve public health by allowing, improving access to specialty and other care. Also, on the other hand, on the protection side, it preserves that state authority over the licensing process. So we have, as you can see from this slide, this has really been embraced. Most states have adopted at least one compact, the vast majority. 35 states have adopted 3 or more, and there's still lots of legislation around that. So right now, and this has grown just tremendously in the last few years, 15 health professions have active interstate compacts for licensing. Much of this work has been for medicine and psychology has certainly been supported from HRSA, but the Department of Defense and the Council of State Governments also been very involved in developing these compacts. Next slide, please. The benefits of the compacts, obviously, as we mentioned, it improves access to services. Also improves continuity of care. it enhances consumer protection and promotes diversity among our healthcare professionals. So it's certainly a benefit to healthcare consumers. Next slide. It benefits providers because it allows them to practice in other member states of the compacts. It improves license portability. It really reduces the administrative burdens of applying for licensure in multiple states. And it allows them to take advantage of telehealth opportunities. Next slide. And it also is a benefit to the regulators. States retain the control over the providers and what they believe is the best scope of practice in their jurisdiction. They facilitate exchange of licensure and disciplinary information, which can certainly protect the public and patients in light of someone trying to skip from one jurisdiction to another to avoid some sort of sanction or disciplinary action. And I think that truly the compacts improve this cooperation, regulatory cooperation, and the sharing of best regulatory practices. Next slide, please. So I'm going to start just with a little bit about what we've learned through the Interstate Medical Licensure Compact. And I will say from our data, at least almost half of the individuals that use the compact are doing it to provide telemedicine services. So we were really pleased that this really is accomplishing the goals that we had hoped it would. We're going to do some more data analysis this coming year that I'll talk about in a moment. But basically, this is a bit different model than the others in that it is really based on an expedited licensure process. So physicians actually receive a license in every state that they are practicing in, but it's really based on the licensure and qualifications that are confirmed by their primary state. So it is now the first license was issued through the compact in April of 2017. And so to date, they've issued over 75,000 licenses, and the compact has grown from to 39 states plus the District of Columbia and Guam. And we expect over the course of the next legislative session that we will have additional states joining. There is quite a bit of interest out there. So only in the month of July, we've seen over 3,000 licenses issued. So that seems to be about the normal, somewhere between 2,500 and 3,500 licenses a month. Next slide, please. So we, as I said, we through our in this program year with our grant, we're going to be doing some analysis of the data and looking at also trying to facilitate states as they pass the compact legislation. There has to be some staffing, technical assistance, and other things to requirements that allows them to actually implement and start being fully successful in achieving the compact goals. We're looking at the demographics of who the physician population is that are using the compact, and looking at their licensure behaviors and any disciplinary patterns. Thus far, we have seen very little discipline or complaints arising out of those that have gone through the compact. And we're going to be working with the Center for Telehealth at the University of Mississippi Medical Center to looking at data from the FSMB as well as from the Interstate Medical Licensure Compact with CMS public claims data to see where and what procedures, where is this really being utilized. I think this will be very valuable as we move forward and be able to demonstrate the success of the compact. Next slide, please. So now I will turn to our newest compact, which is for PAs. This is the website that it has a lot of information on it. It has the model legislation, places for testimony, FAQs, and we will be adding resources as this project moves forward. Next slide. So a little bit of background. The PA compact is really new. The model legislation was not finalized until November of 22. And since that time, we have tried to educate and partnership with the Council of State Governments, the American Academy of PAs, as well as the National Commission for Certification of PAs, to really get the word out and educate the states and show the benefit that this will allow. PAs are very active in the area of telemedicine and could certainly contribute to our access and workforce issues. This compact model is based on a mutual recognition model, and it means that all of the compact member states will agree to a recognized valid unrestricted license in one of the compact states, which will allow them, as long as they meet some other eligibility requirement, to practice in the other states. Next slide. So as I said, it's very new. So we were very pleased to see that it has already been signed into law in Utah and Delaware. Legislation is currently pending in Wisconsin and Ohio, and in Nebraska, a legislative ordered feasibility study is going on as we speak. So what we are working with on funds for this year is to expand our education and outreach, to look for be ready when the 7 states that will trigger the compact, when that happens, that we are ready and have the technical solution that would support this compact, that for very immediate, if you will, or rapid verification of compact eligibility, and also providing all the legal and technical assistance that ensures that the states are, that the commission will be ready for this PA compact to become fully operational. Next slide, please. So other states, as far as portability, there are a number of states that are working in addition to participating in the compact, but they're also doing something more specific to telemedicine, interstate telemedicine. And this map is shows that there are very different approaches to how you approach telemedicine, whether there's exceptions, or if they have a registration process, or even if there is certain waivers. There are a few states, DC, Maryland, Virginia, have a regional understanding or reciprocity understanding. So I think that we will continue to see these different models and different approaches that exist, and also looking at what has worked best and what hasn't. But I think this is really, it's important to understand for the providers and other entities to understand that it's really it's really critical to understand what these different models are in the states, to as they move forward with their services, to understand these variances and be sure that they're in compliance or taking advantage of some of these processes. Next slide, please. So now I'm going to, in our last few minutes that we have, I want to turn the presentation to talk just a little bit about Provider Bridge. Provider Bridge was a program that was funded by a grant, and it really came in the very beginning stages of COVID, when we were looking for volunteers to be able to help out in these hotspots. And it was important to figure out how we could vet these individuals, and states were struggling with that. And so this Provider Bridge platform was established, and with our partners within the PA community, the nursing community, as well as the American Board of Medical Specialties, all feed into this project. And it's really been it's really a really cool platform. And now that we have wound down from the pandemic, we're very excited about repositioning this Provider Bridge to have it as really in the toolkit of the nation's emergency preparedness, to be able to utilize the workforce that is out there to get them in places of need. Next slide, please. So as I said, we are pivoting Provider Bridge away from only being very COVID-centric to really show how it can be a wonderful tool in responding to any public health emergency as they arise. It could be a local, regional, or national emergency when you're trying to identify some providers that would be willing to come in and help in those areas. It's also will allow entities to come in and use this process as well. Next slide, please. And these are really, we are now in the process of rebranding this project. So if you went on to the Provider Bridge website, you wouldn't see this yet because we have just begun this work and are really trying to reposition it, do the necessary outreach and understand where those touch points are with providers that allows folks to even know this exists. So as I said, it is for both healthcare professionals. Right now, it is physicians, PAs, and nurses, but also for healthcare entities that can be registered and they're able to search and locate their volunteers. Next slide, please. So an entity can register a hospital and they can search a database and find credentialed healthcare providers. They can find out where they're licensed. And so if they would be able to immediately work there, if there's no waivers in place. And so it is something that we're really enhancing this year and really basically trying to get the word out. There are over 200,000 health professionals registered currently, but we really believe that if it is people knew more about it, that they would be willing to opt into the program and be able to immediately receive a passport at the time that it's needed. So next slide, please. So the Provider Bridge, it's very simple to use. If you were to register as a healthcare professional, you can either go by name, by specialty, by location, and then begin the process. And in minutes, you can receive your passport. Next slide, please. So then I think in summary, I just want to say this is really something that we are excited about. We want to, I was happy to have this opportunity today because I think this is just something that really is a tool with wherever your practice, whatever your specialty is, and in the event of trying to identify people that would be willing to come in and help in whatever the situation. And I'm happy to provide more information about this and you will have my contact information. Next slide, please. So there's my email. Please, anytime you have a question or would like to learn more about any of this work that we're doing, any interest that you have in promoting any of these initiatives, we would certainly appreciate that. And now maybe there's a minute or two for questions. Thank you.
Yes, there are. In fact, stick around here, Lisa, and others, Sandy and Robert, come on back. But Lisa, I'll start with you. There's a question, and I'm curious about this myself. Anthony writes, I understand states prefer medical licensure compacts instead of universal licensure for multiple reasons. Can you comment on what's being done to assess provider satisfaction with licensure compacts and how the providers, various kinds of providers, feel about the feasibility, ease, and cost of licensure compacts? Is that something you can address?
Well, I think so. I think this is something, and as I said, I think we have to recognize that the compacts are different. Medicine is a different model than the others. So there's a lot of difference in the compact, and that may have something to do with the satisfaction that folks are finding. I know with the medical compact that they're very aware of this, and they are actively doing things to improve the physician user experience. They're going to be doing a lot of technical enhancements, and over the course of the next year, they're hoping to have some real progress made by the end of next year. And I think through they do some, I think they try to gauge that. I know that it's a bit different on fees and what it costs. I know that from the employers that they have been very satisfied because it has saved them a lot of money and administrative work in getting their physicians licensed quickly. So I do think this is something that I think we will continue to hear feedback and invite feedback on the satisfaction, because I mean, really, looking at all of those factors that Robert brought up about burnout and folks quitting and everything else, we have to look at on every level of what barriers and maybe unnecessary barriers that we're putting in place and trying to ease those administrative burdens. I mean, from the regulatory perspective, I think that's all we can do. But I do think it takes everyone to look at this and see what we can do to support, you know, the satisfaction and wellness of our health professional workforce.
Yeah, thank you, Lisa. I know that's a challenging one, and it's a struggle. And I want to underscore something too that was part of your answer, and I think all of us touch on this, and certainly us in the Telehealth Resource Center world do, that whether any aspect of telehealth, whether it's the licensure aspect, workforce portability, policies of various kinds, telehealth is so multifaceted. And people say, well, does this service get paid for? Or can I get paid for doing this? And it's like, okay, what kind of a provider are you? How are you licensed? What jurisdiction are you in? Who's the payer? What kind of a patient? I mean, there are all kinds of details. And we certainly don't want to scare anybody off. It's not too difficult, but there are layers upon layers of kind of complexity here. And there's still a lot of effort to be made, I think, in simplifying the pathway between traditional practice and a fully digitally enabled telehealth practice that isn't immediately tripping over itself because, oh, we just crossed a border there, or, oh, you're a different licensure than I have, and all of that sort of thing. So lots of things to be thinking about, lots of progress to be made. I am going to say, instead of doing any questions, we only have a couple of minutes left, but what I'm going to do is I'm going to just tell everybody, contact information is available. These folks are fabulous resources. And if you can't reach them, or if in addition to reaching them, you want to reach out, and this is, I guess, a shameless plug, but the Telehealth Resource Centers, we provide free resources. We're federally funded. Please reach out to one of the Telehealth Resource Centers. We can get you up to square one and certainly beyond that, and then connect you with any other resources that you need in the country for telehealth. So do take advantage of that, as well as reaching out to these presenters. I will say on behalf of myself, thank you very much, everybody. This was a fabulous session, wonderful information. And I'll remind all of our viewers and attendees, the next session starts pretty much immediately. So get to the link on the website and get to the next session, because it'll be starting right away. Again, thank you, everybody. Fantastic session.
Thank you.